going to be speaking about sort of updates in polymyalgia rheumatica. And I titled this talk, So What Has Changed Since 1957? So why did I invoke the year 1957? So that was the year the first use of the term polymyalgia rheumatica is seen in the medical literature. Now, the disease was probably first described back in the late 19th century, and certainly in the 1930s or 1940s, you could see authors struggling with this population of patients that sort of looked like RA, but had a little bit of a different phenotype and different characteristics. But the first actual use of the term polymyalgia rheumatica was in this case series by Dr. Stuart Barber from the UK. And what's really interesting is that in his series, this is just 12 patients, he really identified the sort of canonical characteristics of PMR that we still sort of reference today. So number one is that it's really a disease of the elderly. So the average age is about 75. And so it's almost never seen in patients below 50. One is that unlike rheumatoid arthritis, right, which typically affects the distal joints, like the wrists, the MCPs, this really has a trophism for the kind of muscles surrounding the shoulder and the pelvic girdle. And, you know, these patients are often kind of extremely stiff and sort of extremely painful. So the way I tell kind of fellows is that these patients really fall off a cliff. So like last week, they're hiking, they're, you know, playing pickleball or whatever, and then now really they can't get up the stairs. So I specifically remember there's a patient of mine who's actually a personal trainer. So he's very buff, and then he had to actually start sleeping downstairs because he couldn't actually go up and down the stairs. So it's a really dramatic kind of functional decline that you see in these patients. And this is the kind of visit where, you know, the kind of adult children will come with the patient because they're so worried about what they've seen and how they're doing. And so I like this quote from Dr. Barber. He said, "The somewhat melodramatic description of their pain by these patients tends to suggest a diagnosis of psychoneuroses until the ESR has been measured." But like when you see kind of the faces of these patients, I mean, they just look like they've been hit by a truck, right? Because again, 2 weeks ago, they're totally normal, they're doing their thing, and now they're really, you know, they just cannot get out of bed in the morning. As Dr. Barber mentions, right, these patients almost universally have elevated inflammatory markers. So maybe about 10% of patients can have an ESR less than 40, but virtually every patient will have an elevated CRP. And certainly if both the ESR and CRP are normal, you really have to really think about other diagnoses. Unlike rheumatoid arthritis, polymyalgia rheumatica is not thought to be a destructive arthritis, right? So you do not see the joint deformities, right, that you can see with rheumatoid arthritis, and X-rays in these patients are typically normal. Now, Dr. Barber did not have access to a lot of antibody tests, but he did note that the so-called lupus erythematosus cell was negative, which is sort of the early kind of ANA test that people used to use. And still to this day, we have not developed any autoantibodies, right, that lead to the diagnosis of polymyalgia rheumatica. And even though the name myalgia, right, suggests that this is disease of the muscles, the strength on these patients, if you're able to test them, even though they will feel weak, but the actual strength on testing is typically normal. They will have normal CPKs, and muscle biopsies, which you don't do anymore, but they did when this disease was first being diagnosed, including in this case series, are typically normal. And, you know, PMR is sort of characterized by a very good response to relatively low dose steroids, which Dr. Barber did note. And he said the greater availability of the corticosteroids made it possible to try their effect, and there was no doubt of the immediate response to these preparations. And so this is an funny quote, and he said, this is from this paper in 1957, he said, "Until more is known about it, I suggest the term polymyalgia rheumatica." And he would prescribe bed rest and phenylbutazone, which is sort of like an old NSAID, right? Now, that term, he was wrong about one thing, and that term is still used, right? So this is what we call this sort of syndrome or disease today. But I really want to identify what I'm trying to give you is an update on what things have changed since then. And we're going to talk about 3 different things. One is how advanced imaging has helped us figure out kind of where the lesion is polymyalgia rheumatica. One is that our increasing knowledge about the relationship with this disease with giant cell arteritis. And then certainly, in addition to steroids and phenylbutazone, right, we have new treatment options that I'm going to talk about a little more. So whenever I give, one of these grand rounds, and I always tell the fellows this, I preach them, I say, if you're going to give a talk, right, the question is, why should the audience care, right? You're taking up some amount of their time. What's the point? Why is this all, I think, interesting to a general medicine population? And there's sort of, I think, two reasons. So number one is that polymyalgia rheumatica is a common disease. So it's thought to be the second most common autoimmune rheumatic disease in the elderly, besides elderly onset rheumatoid arthritis. Some prevalence estimate that almost 2% of the population will have PMR. So even certainly if you go into general medicine, you're going to see this, but you will encounter this in any field of medicine that you go into. Now, interestingly, there's this kind of, at least in Europe, there's sort of a north-south European prevalence gradient. So the prevalence is much higher in Northern European countries than in Southern European countries. And there's very low prevalence in Turkey and Korea, and then in Colombia, which I don't think is listed on this map. Now, the US prevalence is thought to be sort of in between those Northern and Southern Europe. With the caveat, right, is that all our knowledge about the prevalence of PMR in the US comes from the Mayo Clinic and their Rochester Epidemiologic Project, right? So, which is a relatively small area, right? And certainly not, doesn't reflect the sort of, large diversity, geographic, racial, ethnic diversity of America. So don't really know exactly what the prevalence is of PMR in this country. But in general, it's thought to be very common. And the second reason, right, and this is, I think, the more important reason that it's really important for all of us to know about, is that this is a fixable problem, right? Can be a devastating disease in terms of, again, the effect on patients' functional status, but it is something that's very fixable and intervenable, right? So I'm always struck in medicine, right? There are so many things that we can't fix, right? Right? Even today, right? We can't do anything about chronic fatigue, patients with chronic back pain. There's certainly management strategies, but there's no easy fix to those problems. PMR, in contrast, is very much a fixable problem. So this is something I hope that, again, even if you don't go into rheumatology or primary care, though you at least recognize, because if you think someone has this is certainly a message in MedConnect to your rheumatologist. And just as an example of this, in Denmark, in this sort of hospital system, they opened up a fast-track clinic, and after opening up that fast-track clinic, they were able to decrease the rate of hospitalization for PMR by 6 times. And so illustrating the fact that, again, this is important to recognize because you can intervene and improve outcomes. All right. So the first sort of theme or sort of theme that I'm going to talk about today is where the inflammation is in polymyalgia rheumatica, right? As I mentioned before, it's not thought to be in the muscles, right? Again, the CPK is normal, muscle biopsy is normal. And it's probably not in the joints themselves, right? When you do a biopsy of someone of a joint in rheumatoid arthritis, it really looks like a cancer. It's like this exuberant inflammatory response. Joint synovial biopsies in polymyalgia rheumatica do have some inflammation, but it's certainly many degrees less than in rheumatoid arthritis. And sort of the use of ultrasound and PET scans and MRIs has really helped us kind of illustrate where the problem is. Now, polymyalgia rheumatica, in about 20 years ago, was identified that most of the inflammation is thought to be extracapsular, right? And what does that mean? Can you guys see the pointer? Yeah. So this here, I'm colorblind, so I actually can't tell if this is red or green, but this is the joint space in here, and then surrounding it is the capsule. So again, rheumatoid arthritis has a strong predilection affecting within this structure. Well, as polymyalgia rheumatica, really, when you do studies, the inflammation is really kind of in the periarticular areas or extracapsular areas around the joint. And this was seen kind of elegantly first on an MRI study about 20 years ago now. But if you look at rheumatoid arthritis, again, all this sort of swelling is inside the joint, and there's a little bit of a subacromial bursitis. In contrast with polymyalgia rheumatica, it's sort of this kind of fluffy inflammation that doesn't seem to localize exactly to one specific area. It's a lot in sort of the tendons, kind of sort of the myotendinous junction here. These are all kind of rotator cuff tendons. This is the infraspinatus back here, supraspinatus up here. But it's sort of this kind of non-specific fluffy inflammation, but it's really primarily kind of around the joint. You can see here in the hip, right? Again, the hip joint is here, and that actually looks pretty normal. However, right, you see pericapsular enhancement here and then enhancement around the tendons over there. And this is again, very, very striking when you look at sort of hip MRIs. You'll hear this term a lot in polymyalgia rheumatica called myofascial inflammation, which is a little bit confusing because typically when we use the term myofascial, it sort of means essentially like a central pain sensitization, like a fibromyalgia component. But here, when they're talking about myofascia, they're literally talking about inflammation of the fascia and surrounding connective tissue around the sort of muscular tendinous junction. And again, this is really notable mostly. I think this has the most potential in looking at the hip muscles in the pelvis. So PMR seems to have a very striking predilection to affect particular hip and tendon and muscle insertions around the hip. So one here is the rectus femoris. So this is one of your hip flexors, right? You can see it inserts here onto the anterior inferior iliac spine. So this kind of inflammation around kind of the tendon insertion there. And then number two is the adductor longus. So here it inserts onto the pubic symphysis, right, to adduct the hip. And you can see this kind of inflammation here. And this is sort of unique in terms of different inflammatory diseases. Sort of like in the shoulder, you often will get this kind of non-specific inflammation. And again, I can't tell you, there have been a number of times where I've gotten MRIs of this and it'll be sort of read as like, muscle strain or something like that. But it really, this sort of bilateral enhancing nature of it should really clue you in that this is polymyalgia rheumatica. We're looking here from the posterior aspect. You can see the inflammation of the gluteus medius tendon here, and also of the hamstring insertions here on the ischial tuberosity. And then again, we have all these sort of like these kind of 6 very small hip extensor muscles or lateral rotators kind of in the back of our thigh, like the obturator externus. And again, notice that the inflammation is kind of in the fascia surrounding the muscle as opposed to in the muscle itself. And again, in all these situations, the actual joint inflammation is relatively minor. And so it's really thought, again, that the inflammation in polymyalgia rheumatica seems to start at the musculotendinous junction and in the connective tissues around that junction, and then can subsequently spread into the surrounding bursa or the joint. So again, it does not seem to start in the muscle like in a myositis. It does not need to start in the joint itself like a rheumatoid arthritis. It's in these sort of like periarticular connective tissues where the inflammation starts. And that seems to fit with our kind of the kind of clinical presentation, where they have a hard time exactly localizing kind of where the pain is. They just know that they're in kind of big trouble. Now on ultrasound, there are a couple of things that you might see on ultrasound. So one is a subacromial bursitis. So I don't know how well this projects, but this is the supraspinatus tendon. This is the deltoid, and this swelling here is the subacromial bursa. The other thing that you can see on ultrasound is a biceps tenosynovitis. So this is inflammation in the tendon sheath. So here's the biceps and this surrounding kind of halo of inflammation that you can see both transversely and longitudinally is inflammation. But as I said before, I think these are probably secondary inflammatory changes as opposed to the primary site of inflammation. And so in the ACR, this is the American College of Rheumatology classification criteria, you can actually use ultrasound to as part of the criteria. But note that ultrasound doesn't really increase your sensitivity and specificity that much. And again, I think the problem is, number one, is ultrasound. Like, I love ultrasound. As Dr. Steen said, I do a lot of ultrasound. It's can be amazingly helpful in clinic. But there's a lot of operator dependence, sort of how much jelly you put on, kind of how you hold the probe. Are the lights out? Is the patient, is there a lot of fatty tissue between, the probe and what you want to look at? But also, the problem, again, I think that the problem is that we're looking with ultrasound for sort of these like secondary and tertiary changes as opposed to the primary inflammation itself. Now, there's been a lot of investigation about PET scans, and PET scans do seem to have a relatively high sensitivity and specificity for the diagnosis of polymyalgia rheumatica. And you can see around the sort of shoulder, the hip girdle, and the ischial tuberosities here, that's that hamstring inflammation that I was talking about on MRIs. What's notable about PET scans is that you can identify, they have sort of found kind of interesting new sites of inflammation that you can see, such as the intraspinous bursa. So these are these bursa that are in between the vertebrae, and that's probably an explanation for a lot of like the neck and lower back pain that these patients get with this disease. Now, PET has a major role in identifying concurrent large vessel vasculitis, which I'll talk about a little bit later. And I think it's generally probably too expensive and too much radiation for routine diagnosis for polymyalgia rheumatica. But using PET scans has helped us identify a couple of these sort of interesting new locations that we weren't really thinking about before. Again, what I think probably has the most potential for the diagnosis of polymyalgia rheumatica is MRI with contrast, specifically of the pelvic girdle, because that's sort of there's not like it's very there are not a lot of other places that cause inflammation sort of in that way. And you can see from this study, this is a retrospective study, so you have to take this with a grain of salt. But you can see that, again, at that rectus femoris insertion and at that adductor longus insertion, almost every patient with PMR will have that, where it's very, very uncommon in controls. And these are controls who had MRIs done for pelvic pain. Now, again, this is a retrospective study. A lot of steps need to be done before this is ready for prime time, prospective, multiple centers, randomized, blinded, et cetera. But I think doing MRIs of the pelvis for these patients has a lot of potential in terms of aiding us in the diagnosis, because right now the diagnosis is purely clinical. I mean, all diagnosis in rheumatology are clinical, but right now we don't really have any imaging. I think is routinely used for diagnosis, and I think an MRI of the pelvis really has potential for that moving forward. So now I want to speak about the relationship to giant cell arteritis. And this is actually that relationship has not actually been is not actually new, but a lot of our sort of more knowledgeable relationship is new. But in 1964, this paper came out with the sort of passive aggressive title of arteritis and quote polymyalgia rheumatica. So this was a hospital in Sweden called Vaxjo. I'm not sure if I'm pronouncing that correctly. It does look very nice on Google Maps, but they took 23 consecutive patients who were admitted for polymyalgia rheumatica. 14 of those patients had no signs of giant cell arteritis. 12 of those patients had a biopsy of a temporal artery. So again, these patients had no cranial symptoms. They biopsied the temporal artery, and half of those patients ended up having features of giant cell arteritis. And so these authors concluded that no, polymyalgia rheumatica is not a form of rheumatoid arthritis. This is actually, quote, temporal arteritis in one of its several guises. And so they actually proposed the term polymyalgia arteritica, which has not stuck, but I think it's an interesting term. We know that at least clinically, about half of patients with giant cell arteritis will have polymyalgia rheumatica. And in contrast, about 10% of patients with polymyalgia rheumatica will have giant cell arteritis either at diagnosis or moving forward. So when I see patients with polymyalgia rheumatica in my clinic, every time I'm always screening for symptoms of giant cell arteritis. And so this has led some authors to propose the, quote, one disease hypothesis. So people will argue that these diseases are essentially two parts of the same spectrum, and they will call it GCA/PMR spectrum disease, or GPSD. So what is the evidence that they use for this? So number one is that, again, so very interestingly, if you take a patient who comes in your office, they have classic PMR, they respond to steroids, relatively low dose steroids, about 25% of those patients will have evidence of a large vessel vasculitis that is subclinical on some modality, right? So either via temporal artery biopsy or an ultrasound. And in this case, I'm not talking about ultrasounding, their shoulder. I'm talking about ultrasounding their temporal arteries or their axillary artery or their subclavian artery, or on PET scan. So about 25% of these patients will have, quote, subclinical giant cell arteritis. And sort of, as we'll talk about in a second, one of the mysteries and sort of one of the future steps is going to be trying to figure out, are these patients different in some way than the 75% of patients that have more, quote, pure PMR? Another line of evidence that they use to kind of connect to these diseases is the epidemiologic overlap. So that sort of north-south European gradient is also seen for giant cell arteritis in addition to PMR, and obviously both are seen in the elderly. So again, both have a predilection for 75, and both are again exclusively seen in patients above 50. And there are a lot of like shared immunologic pathways. So they both are diseases essentially of myeloid expansion of the myeloid lineage, and both are associated with increased production of a particular cytokine called interleukin-6, which is going to come up later when we talk about treatment. And there are even some even more direct connections. So in some mouse models, if you take a mouse, PMR mouse, and you add an artery, you transfect an artery of a mouse with GCA, the inflammation in the T cell inflammation will migrate into the temporal artery of the patient with of the mouse with PMR, not with controls. So it's thought that perhaps the temporal artery of the mouse is somehow sort of activated and just awaiting that second hit to get the vascular inflammation that's characteristic of giant cell arteritis. So if you were going to do an ultrasound looking for a concurrent vasculitis or vascular inflammation with PMR, what you're looking for is something called the halo sign. So the top panel here, this is normal. The bottom panel, you see this hypoechoic, minimally compressible surrounding halo inflammation around the artery. And this is thought to be thickening of the arterial wall. So if you're going to do an ultrasound to look for a large vessel vasculitis, you will look for this sign either in the temporal artery, the subclavian artery, or the axillary artery. And what's really notable, and this is a little bit confusing, so just stay with me for a second, but if you take patients with, again, subclinical PMR with evidence of vasculitis on ultrasound, and you compare those patients directly with patients with pure vasculitis, pure giant cell arteritis, they look a little bit different, but there's a lot of crossover just in terms of the distribution of the vessels involved. Again, suggesting that there's a lot of overlap kind of between those two diseases. Excuse me. Similarly, when you look at PET scans, right? So if you do have someone with sort of pure PMR, again, you can see the inflammation around the shoulders, around the hips, in the interspinous bursa here. But a lot of these patients will have, again, 25% of these patients will have concurrent vascular inflammation too. And so the question as that is going to be moved forward is, do these patients act differently in some way? So are these patients who, again, have PMR but also have evidence of vasculitis, are they treated differently in some way? Are they more refractory to therapy? Do they need a higher dose of steroids to control their inflammation? Should they be given more steroid-sparing agents right up front? And then again, it's sort of really importantly is, are they at risk for some of the terrible complications of giant cell arteritis that we worry about, notably visual loss, aneurysm formation, and as well as sort of large artery stenosis. And that again is sort of a sort of really important question. Again, whether that 25% of patient act more like giant cell arteritis or they act more like polymyalgia rheumatica. And that's sort of an active area of research kind of as we speak. And then finally, I'm going to talk a little bit about updates in treatment for this disease. Now, polymyalgia rheumatica is typically thought to have a very, very impressive response to relatively low doses of steroids. So this is a very famous picture in the rheumatology world. But this is a guy who is diagnosed. This is at diagnosis, and you can see he cannot abduct the shoulders past 90 degrees. And that's probably the most common physical sign that we'll see with polymyalgia rheumatica. In contrast, in panel B, this is after a week of corticosteroids, and he's able to fully abduct the shoulders. So steroids are typically thought to have a very, very impressive response, again, in relatively low doses of steroids in patients with polymyalgia rheumatica. So in the 2015 recommendations for the management of PMR, and this is through the American College of Rheumatology, as well as the European League Against Rheumatism, which always kind of tickles me about why they called it that. But they recommend starting at 12.5 to 25 milligrams a day. You taper to 10 milligrams after 2 months, and then you decrease by 1 milligram per day every 4 weeks. So that's a long taper, right? So if you're diagnosed January 1st, March 1st, you hit 10, right? And then April, you're at 9, and May, you're at 8, and June, you're at 7, right? So it's a very, very long taper of steroids. And that is obviously problematic, one, for side effects, but two is just the efficacy, right? So this is a particular observational study, and I want you guys to focus on the complete response to treatment here. And you can see at week 4, about 70% of patients have a complete response. Now, some of us in rheumatology might say, oh, that actually seems a little bit low, right? Because most of these patients seem to have a complete response very quickly to steroids, almost everybody. But probably some of that remaining 30% is a lot of mechanical disease, right? So, they have concurrent rotator cuff disease or concurrent AC joint arthritis, for example. But again, I mean, the initial response is not perfect. And then as you taper the steroids, right, fewer and fewer people are in complete response over time. And so in general, right, we find that about half of patients just on steroids will relapse at a year, and to require steroids long term is very, very common. So a systematic review found that 3/4 of patients are still on steroids at a year, 50% are still on at 2 years, and then 25% are still at steroids at 5 years. And we know, right, that the side effects of steroids are very cumulative, right? The higher the dose, the longer you take it, sort of the more side effects. And this is the, list of side effects that you can get with steroids. Now, in rheumatology, there's been this development of the glucocorticoid toxicity index, which is a index to sort of identify toxicity of various regimens and how they affect how the steroid burden affects patients. But I would note that a lot of steroid side effects that bother the patients the most are actually really hard to capture in a tool like that, right? So things like, obviously weight gain, but stria formation, cushingoid features. A lot of patients, I don't know if you guys have experienced this, but a lot of patients on steroids describe just the easy friability of their skin as being a really, really problematic. And so a lot of that, but again, a lot of that is going to be very hard to capture just in a tool. But again, we do know that it's really the toxicity of steroids are sort of very cumulative. But you might say, all right, well, a patient's on steroids for 5 years, but let's say they're on, they alternate between 3 and 4 milligrams for 5 years, right? So what's the big deal? Well, I think the side effects of even low dose steroids are sort of starting to become, when used chronically, are starting to become more and more known. So I think a lot of us know that even low dose steroids can increase your risk of fractures, specifically vertebral fractures. So again, these are patients on 5 milligrams a day or less. Long term, that doubles your risk of a vertebral fracture. And we'll say I don't think that's like dramatic news. But what has really struck me is that even low dose steroids do seem to increase your risk of serious infections. So this is a observational study looking at 2 different databases. One is in Medicare, one is a commercial database. But you can see here that the patients on 5 milligrams a day or less, right, still had a significantly increased risk of serious infections. Because I think when I was in training, right, the mantra was you quote unquote make 5 milligrams of prednisone a day. So if you're on prednisone a day, 5 or less, it's still like quote unquote physiologic. But again, data really suggests that it still has potential toxicities. Right. So you might see here, well, the number needed to harm, you go from 8.6 to 11%. The number needed to harm is, I don't know, about 45 or 40. It's not terrible, but, if you're that one patient, that's a big problem. And sort of similar observational studies have found the same thing with cardiovascular risk, right? So even low dose steroids here can increase your risk of AFib events as well as CHF events. And I definitely have had patients who I've put into AFib on steroids at the doses used for polymyalgia rheumatica, unfortunately. And I think one thing that we really don't appreciate in rheumatology, I don't know if any of the endocrinologists are here, but a surprisingly large percentage of patients on low-dose steroids will have evidence of adrenal insufficiency as well. And so this is from the UK, the SST. This is like their ACTH stim test. And this is a cross-sectional study of patients in rheumatology on long-term glucocorticoids. And of the patients on 5 milligrams or less, I think this is about 25 to 30% of patients still failed their ACTH stim test. Now, this is they weren't doing all comers here, so they were doing this test for a reason. So I can't say what the sort of overall rate is, but it's still suggestive, right, that there's still problems in your HPA axis, even using these low doses of steroids, which our polymyalgia rheumatica patients really see. And again, as you might expect, this has been studied specifically in polymyalgia rheumatica, and those patients have an increased risk of diabetes, a doubling of their diabetes risk, and an increased risk of fractures, especially vertebral fractures, right? So steroids seem to have a predilection for vertebral fractures, and 5-time increase in women, right? So again, this is not an insignificant problem. And so because of that, right, there's been a lot of interest in the use of steroid-sparing therapies for PMR. Now, I think it's important to kind of take a step back here and think about what's the rationale for using a steroid-sparing therapy, right? So number one, right, is obviously you want to decrease the steroid burden to decrease the risk of side effects. And so that's what I've been talking about for the last few slides. Again, these patients do have a long-term steroid exposure often. So yes, a steroid-sparing therapy, I think is important just for that particular reason. The other two reasons that there's actually less of an impetus for PMR than you might think, right? Because another reason you might want to make sure someone is on a steroid-sparing therapy is to decrease your risk of flares. And obviously that depends a lot on the consequences of a flare. So if you have someone with PMR and they have a flare, it is distressing to the patient, but it's usually fixed relatively simply with a relatively small increase in steroids. So you have someone on 5, they flare, you bump them up to 10, they're kind of back to normal, and then you can kind of taper down, okay? But again, you don't have sort of a lot of morbidity associated with the flare. In contrast, right, in something for like giant cell arteritis, right, a flare can obviously be quite catastrophic, right? I'm showing you here an anterior ischemic optic neuropathy, which will cause irreversible vision loss. So, based on that, right, the threshold for steroid-sparing agents for polymyalgia rheumatica is actually a little bit higher than you might think for giant cell arteritis. And the third reason you might use a steroid-sparing therapy is to prevent sort of joint destruction, like in rheumatoid arthritis, as you can see here. So in rheumatoid arthritis, right, we know that disease-modifying agents, when used early, will prevent long-term consequences. That's why in rheumatoid arthritis, we think about this window of opportunity, right, where you want to get patients on methotrexate early, because we know if you control their disease early, even down the years, 5 years down the road, they have less radiographic progression. But as I mentioned before, excuse me, polymyalgia rheumatica is not a joint destructive disease. So for that reason, right, again, the threshold for using a steroid-sparing therapy is going to be a little bit higher for PMR than for rheumatoid arthritis, as an example. So now, again, you can always walk into the rheumatology clinic and say, like, oh, that patient should be on methotrexate or Plaquenil, and we'll be like, good thinking, right? Sort of like it's like, medicine grand rounds where you say, oh, it could be syphilis, right? And they'll be, oh, like good thinking. So methotrexate really has been, unfortunately, the evidence basis for methotrexate as a steroid-sparing agent for polymyalgia rheumatica is far less than for rheumatoid arthritis. However, the largest trial and most well-done trial for PMR and methotrexate did show a significant benefit. And this was actually using a dose of methotrexate of only 10 milligrams per week, right? Where typically for RA, we go up to 25 milligrams per week. And you can see that there was the trial was actually out to 72 weeks, and there was a basically halving of the rate of relapses. And as you can see, a lot less steroid use in the methotrexate group. But note that it took a long time to show that, right? You had to be on, it was only about 24 weeks, so 6 months, before you saw that improvement with methotrexate. And so in the American College of Rheumatology guidelines, methotrexate is suggested, but the language is like extremely wishy-washy, right? The panel conditionally recommends considering early introduction of methotrexate. It's like when I tell our fellows, like, I cannot stand when they write, consider this. I'm like, either recommend it or don't, right? We can all consider whatever we want, right? You either should do it or don't. So the panel conditionally recommends considering. I don't even know I have no idea what that means. But certainly the evidence basis for methotrexate in PMR is certainly not the same as it is for rheumatoid arthritis. Now, TNF inhibitors have been studied in polymyalgia rheumatica and have been found to be ineffective. So both infliximab or Remicade, as well as etanercept or Enbrel, have both been studied and both showed absolutely no benefit. Like the Kaplan-Meier curves are like right flat on top of each other. And now there has been a lot of interest in interleukin-6 inhibition in polymyalgia rheumatica. And there's a lot of a number of reasons for that. Number one is IL-6 levels seem to track with disease activity in PMR. So if you are treated and your IL-6 remains elevated, you have a much higher risk of relapse. There are some genetic risk factors in the IL-6 promoter gene that increase your risk of relapse. When you do biopsies of the subarachnoidal bursa, which is actually synovial tissue, there's increased expression of IL-6 in the histology. And as we know, in giant cell arteritis, which depending on your point of view is either a sibling or a fraternal twin of polymyalgia rheumatica, IL-6 inhibition has been shown to be effective. And so we have two options, right? So one is tocilizumab or Actemra. The other is sarilumab or Kevzara. Both are antibodies that bind the IL-6 receptor, either in the soluble or membrane-bound forms. So there have been 3 trials. I'm going to go over 2, really looking at IL-6 inhibition. So the first one is called PMR-SPARE. This looks at newly diagnosed patients with PMR. Now, the field of rheumatology is littered with drugs that failed because of a high rate of background prednisone use, making it hard to show a difference between the placebo and the drug, right? And this is most notable, I think, in lupus, but has been seen in another of other trials. And so if you're a company and you want to show that your drug is effective, you're going to make sure that the placebo group gets the minimum exposure to prednisone that you can get away with. And that's what they did in this particular trial, right? So they started patients at 20, but they got them off prednisone by week 11, right? And again, remember, ACR American College of Rheumatology criteria is that those patients are typically on for a year. And as you might expect, there was a pretty massive difference in outcomes. So the placebo group, so these are the patients who got this very rapid taper, had a very, very low rate of prednisone-free remission, whereas the patients who got tocilizumab or IL-6 inhibition had an excellent, generally a very, very good response. So that's great, but it's probably not the population in which you're going to use one of these drugs, right? And there was a steroid-sparing effect. But the population who you really want is these patients who are a little bit more refractory, right? You want those patients who are on steroids for 1, 2, 3 years and really can't get off. That's really the population you want to see if this very expensive and potentially toxic drug has an effect. And this is the SAPPHIRE trial. So this is looking at sarilumab or Kevzara. And again, this is really exciting. So these patients, again, were not newly diagnosed. These are patients who are relatively refractory. They had to have a recent flare and were on prednisone of 10 milligrams or more. And sort of this is a very gutsy trial, right? So I don't know the inner workings of how this was designed, but I suspect that the FDA made them do it in this particular way. So this was not a trial of sarilumab versus placebo. This is a trial of sarilumab versus a short prednisone taper versus a more conventional prednisone taper. So again, if you were the company designing this, you would not want to do it this way because you're giving the placebo group more prednisone, and that's going to make it harder to show a difference between your drug. And yet, despite that, and so this is just the difference in the steroid dose, and despite that, there was actually a significant benefit to the use of sarilumab. And this is a very, very actually difficult endpoint to reach. This is sustained remission at 1 year. And sustained remission they defined as clinical remission by week 12, and then no flares the rest of the trial. So no flares from month 3 to month 12. And you had to adhere to the prednisone taper. As you might expect in this relatively refractory group of patients, very few of them were able to meet the endpoint, whereas about 30% of patients in sarilumab were. So this is a number needed to treat of 5, which is, again, pretty good for rheumatology. And another way to kind of slice the data and that makes it look a little bit more impressive is just looking at patients who didn't have any signs of PMR, even if they had to have a little bit of steroids. And in that group, right, there's a quick separation at week 4 between the two groups. And so I think this certainly was a very relatively impressive result for this medication. And so now sarilumab is FDA approved specifically for patients who have what they call glucocorticoid resistant PMR, which is a little bit of a misnomer, just patients who still need steroids to control their disease. So this is very exciting, and now it is being approved by insurance. So if you have a patient with PMR who can't get off the steroids or can't tolerate steroids for whatever reason, diabetes, osteoporosis, then this is a really, really great option. That being said, right, interleukin-6 inhibition does have some significant and relatively unique side effects that I think everyone should be aware of. So, the risk of it is an immunosuppressant, right? So there is an infection risk. It's probably a little bit higher than TNF inhibitors. That being said, right, if you remember when I tell patients, like, I'm going to give you this drug, I'm not telling them your options are either this or nothing, right? The options are either this or more prednisone. And so in that particular case, it certainly could be the case that this medicine really does not overall increase your risk of side effects in this population. And certainly in the trial that I just mentioned, the SAFFRO trial, there is no difference in infections between the salutamab group and the higher dose prednisone group, right? Neutropenia is not an uncommon side effect. Probably about 10 to 50% of your patients on this will become neutropenic, and sometimes that can be improved by adjusting the dose. And LFT abnormalities, again, are also not uncommon with this medicine. I think maybe about 20, 25%. Now, a sort of catastrophic side effect that I fortunately am not seen, but is certainly needs to be known, is gastrointestinal perforation. So interleukin-6 seems to be important in forming the mucosal barrier of especially the lower GI tract. So about 1 in 1,000 patient years of exposure to this drug will lead to a GI perforation. So if you're giving this drug over 5 years, right, there's a 1 in 200 chance that will lead to a lower GI perforation. So it's, again, not insignificant. If you have a risk of diverticulitis, that's a risk factor. So I would not say history of diverticulitis is an absolute contraindication. It depends a lot on, again, what the alternative is, but it's certainly a kind of something you really need to think about hard before you administer this. And often when these patients come in, they don't come in with the kind of catastrophic peritoneal signs you might expect. Sometimes it's a little bit more subtle. The last thing about interleukin-6 inhibition that I think, all of you guys will probably come across, certainly in residency, are what I call these practical difficulties. So we know that IL-6 will raise your LDL as well as your HDL level, but it doesn't actually increase your risk of cardiovascular events. In contrast with tofacitinib or Xeljanz, right? This medicine has been studied specifically against TNF inhibitors and was not found to increase your risk of cardiovascular events. But the problem is, by severing the relationship between the LDL and the CV events, you're not quite sure what to do with the LDL data that you get, right? And I've asked this to a lot of people, and there's no correction factor that you use. So it's very hard to put in if someone has elevated cholesterol in this medicine, the Framingham risk calculator is not as relevant as it could be. So that's sort of one kind of practical difficulty. The second practical difficulty, and this, again, something we see a lot in clinical practice, is that interleukin-6 acts on your hepatocytes to induce the production of CRP. So if you block interleukin-6, your CRP is going to go down. But again, now you've lost that as a marker that you can use to see if someone is flaring or not. And again, all diagnoses are clinical, right? But certainly we do use the CRP. If you have someone who has PMR, and they come in and they're having increasing shoulder stiffness, and you're kind of on the fence, you might use the CRP to sway you one way or the other, excuse me. But when you're on this medicine, your CRP is going to be suppressed. And so therefore you kind of lose that ability to use the CRP to kind of aid you in diagnosis. All right, so the conclusions, and I think the things that I really want people kind of to take away here is, number one is, again, PMR is a common disease. But it's very much, it can be very devastating in terms of the morbidity, but it's very much a fixable problem. So if you're thinking this, right, this is certainly a message in MedConnect to one of your rheumatologists. The inflammation seems to be centered around the connective tissue at the musculotendinous junction, and then again will spread to the bursa and the synovium. We know that 25% of these patients who have pure PMR will have evidence of subclinical large vessel vasculitis, although we don't quite know what to do with that information yet. And then again, steroids, as I talked about, in general are very effective, but as you taper them, it's very common to flare. And so therefore, a lot of patients with PMR will need some dose of steroids over years, which obviously can have its attendant side effects. But fortunately, now we do have interleukin-6 inhibitors that are in play, that are FDA approved, that we can use if necessary. So kind of what would I see, what do I kind of want to see moving forward, and what am I sort of excited about? Well, number one is I would like to get a better estimate of the prevalence of PMR, not just in sort of that Rochester population, but sort of more in, again, more diverse geographic settings. Again, I'm looking forward to seeing how the use of imaging can actually help us. Can we formalize an imaging test to sort of aid in diagnosis? So is there a MRI protocol that we'll be able to use that, based on the degree of inflammation in various sites, we can get a good sensitivity or specificity of PMR? And that'll require prospective studies, multi-center studies. Again, the sort of $10,000 question or $50,000 question is PMR, is subclinical giant cell arteritis, so these patients with PMR they have evidence of vasculitis on imaging studies, is it actually subclinical? Or do these patients need a higher dose of steroids? Would they benefit from early introduction of interleukin-6 inhibition? Are they at higher risk for the complications that we typically see with GCA? And if that's true, right, then in the future, I could imagine a future where you diagnose someone with PMR, you start them on steroids, but you say, today we got to get you in for an ultrasound down in the lab, or even do it at the bedside. And they're going to do a formal assessment of your bilateral temporal arteries, your subclavian vessels, your axillary arteries, because if those are positive, then our treatment is going to be a little bit different. And then how to incorporate these steroid-sparing therapies in our sort of armamentarium at the current time, right? Should these be kind of a step down approach where we start these right off the bat? Or should we use more of a step up approach where we let have someone have a relapse and then only add them? And if we're going to do that, can we identify people who are more likely to relapse up front and then say, all right, we can put you into a risk calculator, Miss O'Brien, your risk of flaring over the next year is 75%. Therefore, I think we should start, methotrexate or IL-6 inhibition now. And then again, I don't think this is ever going to happen, but it would be nice to see a comparative effectiveness study of methotrexate or other conventional DMARDs like leflunomide at higher doses with interleukin-6 inhibition, because I do think they probably would be effective.